Okay, good morning, everybody. Thank you again to the committee for the privilege to present today on mycotic aneurysm, a condition we do not have a great way of managing. And when most of these patients present, they really pose a problem or a big challenge, not only to the surgeon who's treating them, but the entire team taking care of them. Here are my disclosures. They actually have no relevance to the talk that I'm about to give today. The first use of a term mycotic, objective first, I guess. I hope that at the conclusion of the operation or the talk today, I hope to discuss the clinical presentation of infected native mycotic aortic aneurysm and aortic graft, review outcomes of medical management alone versus medical management and surgical repair, and discuss the role, if any, of endovascular therapy in the management of patients with mycotic aortic aneurysm. The first use of the term mycotic was by Dr. William Osler in 1885. During his Gastonian lectures, he described the appearance of the aorta and the aortic valve of the patients that had died of endocarditis. And he brought up this term micrococcus while describing the destruction inside the aortic valve and the aorta itself. And he was talking about Gram stain. He used this term Gram with 2M. Presumably, most of these patients were really infected by tuberculosis or syphilis at the time. However, it's unclear in his discourse. It says that this new technique, Gram stain, was a new technique. It's great because if you stain these diseased valves and diseased aorta, you're able to see these organisms under the microscope. And during his publication, he actually brought up the term malignant or mycotic endocarditis, even though this wasn't a bacterial or a fungal infection, but he described how they had fungating appearance under the microscope. Mycotic aneurysms really can be described into two groups. The first group is a primary mycotic aneurysm, and the second is graft-related mycotic aneurysms. Primary mycotic aneurysms can further be divided into two groups. The first is an aortoenteric fistula, and the second is aortic graft erosion. This distinction is very important because aortoenteric fistula is quite different from graft erosion. A fistula is a communication between the two viscous organs. As can be depicted here on the left side, you have a connection between the vena cava and the aorta. So this is an aortocaval fistula. And the second picture depicts a connection between the aorta. You see you have contrast, and it's contrast flowing from the aorta into the small intestine as depicted here. Aortic graft erosion, if you were to ask a lot of GI doctors, they'll have these cool pictures. They were doing an EGD. They get to the second portion of the duodenum. They see this is the mucosa here. You can see that the mucosa, the graft has eroded into the mucosa because of the bacterial infection. These patients will present with something called harrow-bleed. They don't, because the bacteria itself doesn't eat into the graft, but they'll start bleeding very, very slowly, and they're quite sick. If you were to take a very good history of all patients presenting with primary mycotic aneurysms, you will realize that all of them probably had some type of bacteremia, which subsequently they got a super infection of a diseased aorta, disease from either atherosclerotic plaque, aortic ulcer, or aortic aneurysm. And on a CT scan, it just doesn't look like the normal aorta. It looks this funny looking aorta where most patients will have multiple aneurysms. And if you were to open this aneurysm or this aorta, it will look a little bit like what you see over on your right-hand side. And obviously, because the bacteria is eating into the intima and the media of the aorta, then it creates this weakness in the wall of the aorta and creates these pseudoaneurysms. And these aneurysms become very unstable. Left untreated, they can rupture. You can also have some extravascular source that can cause primary mycotic aneurysm, and these include spine infection or osteomyelitis, pyelonephritis or UTI, perforated viscus that can happen during a colonoscopy or a EGD. I recently reviewed a case for our journal where a patient was undergoing bladder cancer treatment with BCG and subsequently developed a mycotic aneurysm. If you have an aneurysm that grows and gets bigger, even an aortic dissection, it can put enough pressure on any organ and eventually can actually erode into that organ over time and cause aortoenteric fistula. And sometimes the infection can be very indolent. The patient can come in and doesn't feel very well. You can do multiple cultures, especially if they've been treated with antibiotics before, that you don't actually see the infection. Primary mycotic aneurysm, fortunately, are very, very rare. They account up to only 2% of all aortic aneurysms. Most of them are circular, and then, as previously stated, are multifocal. Syphilis traditionally used to be the most common cause of mycotic aneurysms. However, recently, there's actually a great divide between the west coast of the United States and the east coast of the United States, and we are included in the east coast of the United States. If you look at most patients that present to our institution or in the east, most of them will come in with gram-negative infection, mostly salmonella. About a year and a half ago, we had this rush of 3 patients here in our institution that we treated with salmonella primary graft infections, and I'll show you some of the examples. I had the privilege of being involved in the treatment of all of them. In the West Coast, most of these patients will present with Staphylococcus or Staphylococcus aureus or some other gram-negative infection. There is a series from the Mayo Clinic where they present E. coli as one of the top 3 organisms, but we know, which is kind of weird, but we know that Mayo Clinic treat a lot of patients from all over the world. Fortunately, primary mycotic aneurysm, most of them, a little over 50% of them are either juxtarenal or infrarenal aortic aneurysm. And I say fortunately because these are relatively easier to treat. All of it taken together, they're harder to treat than a primary aneurysm, but if you have an aneurysm below the renal arteries, most of the time it's easier to treat because you can just clamp and clamp the aorta and take all the dead tissue out. However, 16% of mycotic aneurysm can present in the thoracic aorta. This portion also is relatively easy to treat, especially if it's not involving the aortic arch, because if it starts involving the aortic arch, then we have to solicit the help of our cardiothoracic surgeon patients, colleagues, because these patients need to be treated under hypothermic circulatory arrest. For us vascular surgeon, it is that 33% of patients with either thoracoabdominal aortic aneurysm or juxtarenal or paravisceral aortic aneurysm that really pose a big challenge. And over the next few minutes, we'll be talking about specifically how to address every single one of these 3 groups of patients, and we'll talk about the outcomes that we find in the literature. So what is the treatment? Well, you have an infection by bacteria, so we give them antibiotics. Antibiotics do work for most infection, but what are the results of patients with mycotic aneurysm treated with antibiotics alone? We have 2 different series in the literature that have been discussed. The first and biggest was by Su and al. That looked at patients that came in, they were either too sick to undergo surgery, or they say, you know what, I used to say, well, you're gonna split me wide open and take cut out my aorta and everything. I'd rather take my chances and die. These patients were treated with antibiotics. Mortality was 36% at best, but it's as high as 82%. Dr. Peter Lawrence from the University of California in Los Angeles looked at 22 very high-risk patients who refused surgery, followed them. About half of them, 50%, died within 2 weeks of being admitted to the hospital. The rest of them were discharged to rehab facility, and all of them died within 2 weeks of discharge. So obviously antibiotics don't work because, well, don't work that well because aneurysmal-related mortality in 30 days about 77%, and if you follow them a little further, it'll be higher, nearly 100%, and presumably if you have a gram-negative infection, your mortality is a lot higher. Well, is this the best we can offer? Well, perhaps no. How about surgery? Well, as is the case with anything, if you have an infected tissue, wide debridement in surgery is better than leaving it alone. The question becomes, if you were to resect or debride the aorta, cut out the aorta, what do you replace it with? If you put a prosthetic graft in there, it'll become infected. And aortic ligation was tried in the 1920s and 30s, and people just did not do too well. Then the question we should be asking ourselves, is there a way we can find a conduit that we use to lower the mortality and morbidity of this already vulnerable population, where we can offer them mortality lower than the 77 or 82% that medical management offer? Well, what about using a cadaveric graft? Well, the answer is perhaps. What about using cadaveric graft? This, after all, was used to replace a carotid artery in 1903. And Dr. Gross was the very first one in 1948 to replace the aorta, repair actually aortic coarctation with a cadaveric graft. Dr. Debals, who's a French surgeon who really advanced the field of cardiovascular surgery and vascular surgery, was the very first one to replace infrarenal aortic aneurysm in 1952 with, again, a cadaveric graft. And this remains quite useful to date. Here's a case that I helped Dr. Alim Mirza with. This is a patient that was referred to Dr. Mirza by Dr. Skake, who's actually medicine consulted Dr. Skake, who scanned the patient, and you see the patient has a very big aneurysm, sick, who's growing salmonella in the blood. So in this case, you can see here on the left side, we decided to go into transperitoneal incision. This is the aneurysm that's exposed. We use a cryopreserved graft or a cadaveric graft. Here we have done a proximal anastomosis. The distal anastomosis is no longer done, not yet done into the iliac artery on the right and the left side. And we've brought in omentum. We've wrapped omentum completely. This is the retractor that we use so we don't tire the fellows throughout the operation. How do these patients do? Well, most of the data about the use of cryopreserved graft come from this low-frequency disease consortium, which is an association of 14 academic medical centers in the United States that published their results in 2014 in a Journal of Vascular Surgery. 220 patients were included in this series. About 95% of them had open reconstruction, but there were also 5 patients that had endovascular reconstruction or repair. Indications for surgery was primary prosthetic graft infection in about 65% of the patients, but there were also patients, or 20% of patients that had primary mycotic aneurysm, with 15% of the patient having graft erosion or aortoenteric fistula. 30-day mortality was 9%, which is outstanding. Length of stay was about 24 days. If you look at primary graft patency and freedom from limb loss, meaning these patients, after you do this reconstruction, because the repair it takes so long, they don't lose their leg, 94% and 91%, which is great. However, survival is about 43% to 8 years, with most patients dying within 2 years after you do a surgery repair. The problem with cryopreserved graft is that they're very expensive, about $15,000. There's this group in Norfolk, United Kingdom, said, well, why not just use a bovine pericardial patch? We use this quite a bit to either replace the carotid artery. When we do a carotid endarterectomy, we use a bovine pericardial patch, or when we do a common femoral artery endarterectomy, we use also a bovine pericardial patch. Relatively inexpensive. They had a group of 6 patients that said, let's make our own graft, and this is what the graft looked like. So they essentially just sold their own graft and then came back and used it. They kept all 6 patients on antibiotics. 30-day mortality was 0%. At 13 months, there were 0 or no reinfection and 100% survival rate. This is what the postoperative CT scan looks like. They published their results in the Annals of Vascular Surgery. I'll stop here and says that if you search the literature, perhaps you have better luck, you'll see no other cases like this. And generally speaking, in surgery, if your results cannot be duplicated, your procedure dies. That means that the other people just didn't have a good outcome. So how about using a regular graft? So this is what we use. If a patient comes in with an aneurysm, this is what we replace it with open repair. Well, if you put a graft in there, it'll get reinfected. Is there a way we can really prevent graft reinfection? Use this graft and prevent graft reinfection? Well, perhaps this has been tried. Perhaps we could do that. And it was in the 1980s that people start experimenting different antibiotics. They'll take this graft, the dicron graft that I just showed you, dunk it into antibiotics and test it both in vivo and in vitro and see if they are becoming resistant to an infection. And they settle on this antibiotics called rifampin, which is an old antibiotics that was used in gram-positive. So they added rifampin to stent graft, and they published the results. The best concentration in both in vivo and in vitro was about 60 milligram per milliliter. It was found to be resistant to mostly Staphylococcus aureus, 100% resistant in 7 days, and about 80 to 100% resistant at 10 days. And hopefully at this point, your systemic antibiotics will kick in and take care of the patient. Obviously very popular because relatively easier to do. And when you do it correctly, this is what it looks like. This is a case of a patient that we did. Because most of the aorta, when you're cutting out this aorta, even that at the top is disease, we like to reinforce the ring or the proximal anastomosis, which is we suture right here, the aorta, we connect the aorta to this graft with something called a piece of felt. However, felt was never being tested with antibiotics if it can hold the infection, if it can suck in rifampin that well. So for that reason, we do not use it. What we do, we harvest this fascia on the lateral aspect of the thigh that's called fascia lata, as shown here in a patient that I did. We try to debride all that tissue completely. You go all the way down, you cut out the tissue. We even go down and take the anterior spinal ligament, completely debride it. If we have to debride the psoas on the right and the left side, completely cut out all the aorta and replace it. This is one of the patients that I fixed not that long ago that came in with a gram-positive, was growing a gram-positive cultures, and you can see that this felt, that this is not a felt of fascia. I have used fascia lata for the proximal anastomosis. To further prevent infection, we use this tongue of omentum. What you do, you lift the transverse colon, you bring omentum through the transverse mesocolon, and best to bring 3 tongues of omentum, and you wrap the graft completely. Doing so prevents infection long term. And if you do it right, this is what it looks like. And don't be surprised if you get a call from Dr. Engstrom, as I did in this case, I think this thing is infected. It's not. The reason he's saying this because he's seen all this thing around the graft thinking that maybe it's fluid. It's not. It's actually fat from the omentum that are wrapped around the graft completely. So how do these patients do? Well, the Mayo Clinic is really the one program that has really popularized this procedure. They reported on a graph of a series of 54 patients with aortic graft erosion or fistula. 33 patients had GI hemorrhage. 25 patients presented with fever, and the rest of the patients, about 10 patients presented in hemorrhagic shock. Operative mortality was 2.3%, which is remarkable. However, if a patient presents in shock, their mortality is about 40%. Hospital length of stay was 20 days. 5-year survival was 59%, and lay graft reinfection occurred. There were no lay graft death. However, reinfection occurred in about 2 patients, and both of these patients had abscess and underwent extra-anatomical bypass. We'll talk about that. Dr. Claggett was a a vascular surgeon from UT Southwest in Dallas. He looked at the literature and says, okay, whether you use a cryopreserved graft or you use a rifampin soaked graft, primary patency is really low, except if you're at the Mayo Clinic, it's about 43%. And amputation rate is quite high. Up to 33% of the patients are ending up with an amputation, and the graft is getting reinfected. He said there's a better way, so he comes up with this procedure called NACE, or Neo-aortoiliac system, to replace the aorta. He argues that it's better to use the patient's own tissue, because if you put somebody else's tissue there, it's going to get infected, and this is exactly what it did. This is a case that I did when I was a fellow. I was a second-year fellow. This was a young gentleman, I think he was 48 years old, from Saudi Arabia, who had had an aneurysm of some sort that headed repair in Saudi Arabia. It became infected, it flew, went to the United Kingdom, it got resected, and they placed a rifampin-soaked graft, and that got infected. He went back to the UK, they resected the rifampin-soaked graft, replaced it with a homograft or cryopreserved graft. That got infected again, had an abscess. He went back to the UK, they told them they cannot go back in his abdomen, and they put him on antibiotics, that he was in hostile, the abdomen was too hostile. He took a plane and decided to check himself into the emergency department at the Mayo Clinic. I was on call, and I was on Dr. Manju Kara's service. And this is what we decided to use. He's had a graft that was infected. He's had a graft with antibiotics that was infected. He's had a cadaveric tissue that was infected. We said we got to harvest the vein. If we can't, we might ligate it. But his aneurysm actually extended a little further above the renal arteries. So if you reconstructed it correctly, this is a schematic of it. This is what it looks like. So essentially, you take on one side, you take the deep femoral vein, you go to the iliac artery, and you take a deep femoral vein from the other side, about it on one side, and you go to the left side. And on postoperative follow-up, this is what they'll look like. The problem is this case took us 14 hours to do. Number one, it was very challenging to get into the abdomen. Number two, we had to dig all these veins, deep femoral veins, and cut them out. The risk of limbs loss is quite high outside of Dallas, Texas, where Dr. Claggett used to do these operations. Patients can have compartment syndrome, and the procedure is really, really taxing. It's being called the Whipple of vascular surgery because it literally takes that long. However, if you do it right, the results are quite excellent. Well, what about extra-anatomical bypass? Why not just ligate the aorta and do a bypass from the axillary artery to the femoral artery? Well, the aim of this operation, this is an operation that's done even today. The aim is to revascularize lower extremity before resecting the aorta. And you might wonder, so if you have, and this is what it looks like. So if you have the aorta that's already infected, and this is done a lot of the time in two stages. You do some, unless there are some places that do in one stage. The first stage, you expose the axillary artery here, you anastomose this graft. You expose the common femoral artery on the right and the left side, you anastomose it. You put the patient on antibiotics and observe them afterwards. The second stage, then you go back, you resect this aorta completely, and this is a procedure that works well for patients with an infrarenal aorta, but you can do various alterations of this procedure. You can go from thoracoabdominal artery bypasses depicted here. You can take, even if patients with extra-renal aortic aneurysm, you can even debranch one of the kidneys, take another cryopreserved graft or another graft and go up there, the conduit of your choice. So, how about thoracic aortic aneurysm? What I've talked about so far are infrarenal aortic aneurysm. And as described, this is only 15 or 16% of all patients with mycotic aneurysm. This biggest series comes from Su and al. And experience is really limited, and this was 24 patients. Mortality is anywhere between 30 to 50%. Largest series, again, 25 patients from Su and al., and included 13 patients with aortic arch involvement. And obviously, some of these patients would have needed pulmonary hypothermic deep hypothermic circulatory arrest before fixing them. So some of these patients refused mortality. So in a group of patients that refused mortality, long-term survival was actually 100%. 57% of them died in the hospital. And surprisingly, if you had an operation, mortality was only 12%. However, aneurysmal-related mortality was 28%, and late graft reinfection was relatively low, about 16%. Consideration when you're looking at a patients with thoracic or descending thoracic aortic mycotic aneurysm, you have to ask yourself questions before you get in the operating room. Is the arch involved? If it is involved, again, you're going to need cardiac surgery to help you in this operation, and this adds to complexity and also increases mortality. The question is, what do you replace it with? And the second question that you have to ask yourself in case of thoracic aortic aneurysm is there a communication or a fistula? Most of these patients will present with fistula between the trachea or the bronchus and the aorta, and they can present with a fistula between the aorta or communication between the aorta and the esophagus. And majority of these patients won't do well. A lot of them are older, or they have some type of malignancy, or they have some type of malnutrition, or they have an infection, a bad infection. So if you have malignancy or if you have some type of fistula, these patients do not do well. Okay, so what do you replace it with? Here's an example of a 47-year-old male with Marfan syndrome and type B aortic dissection, presented with type B aortic dissection. He'd undergone a ascending aortic aneurysm repair in the past, and his aneurysm was very big, and he presented with malperfusion of both lower extremities, actually. He was fixed by Dr. Titus and Dr. Moody with a frozen elephant trunk and discharged home and did quite well. 2 months later, presents to an outside institution with fevers, chills, and abdominal pain radiating to the back. A CT scan, if you look on the left side, if you pay attention, at the time I did not pay attention, but if you pay attention, you'll see that there's some air inside the aneurysm sac on this side here. You can see it there. He had not only a ruptured thoracoabdominal aortic aneurysm, but he had an infection that we didn't know at the time. Dr. Domenico Caractera and myself happened to be on call that night. It came in, as is case with most of these patients that come in at night. We took him to the operating room. The aneurysm was about 11 centimeters, just distal to that. So we decided to completely cut out the infected graft, as you see there, and we saw a piece of corn actually inside the aneurysm sac, and you can see a hole in the esophagus. So I said, what do we do? So Dr. Caractera says, well, we cannot call a thoracic surgeon to come and repair this here. He's probably going to die. So I harvest fascia lata from the thigh. We'll reinforce the esophagus. We use a rifampin-soaked graft. We take omentum, bring it back up to the chest. We wrap the aorta around omentum, and we wrap the esophagus with omentum and buttress it all around. He went through it. We thought he was going to die. He was here for over 2 months. But he eventually survived because he was young, probably. After surviving, he went home and came back. He remained on antibiotics. And as luck will have it, his infrarenal aortic aneurysm actually degenerated in his iliac artery aneurysm. So I took him in, and I decided to repair his infrarenal aortic aneurysm. He was now bacteremic at this point. I used a rifampin-soaked graft, and I harvested fascia lata, again, as shown here. I reimplanted his IMA, or inferior mesenteric artery, as well. This is postoperative CT scan. He's done remarkable. He's off antibiotics and is one of my good friends, and I have permission to show this picture. You can see that his entire aorta now is replaced. The only segment that's left behind is the one between the visceral arteries, and if he comes back, I plan on fixing him with a fenestrated stent graft or branch endograft. So, how do patients with thoracoabdominal aortic aneurysm do, and how do we address this? I'd like to limit our conversation here to extent 3 to 5 thoracoabdominal aortic aneurysm because if a patient has an extent 2 or 3 or 1 thoracoabdominal aortic aneurysm, they're going to need cardiac surgery to work with vascular surgery. Dr. Ballard was a vascular surgeon from Loma Linda University, now practicing in Orange County, California, who had an interest in perfusing the intestine while repairing extent 3 to 5 thoracoabdominal aortic aneurysm without using extracorporeal pump. And this is how you position a patient using the Ballard technique or repairing any thoracoabdominal aortic aneurysm. The patient is positioned on a bean bag. You use a Freddy, you take the left arm, position the patient there. It's very critical to take your time while positioning the patient because this will be key. We take a bin bag, we put under the patient, and we take another bag here, as you can see, a bump here, so that we can break the table, so to say. Doing this will help you really expose the aorta. And once you have where you enter the chest cavity and the abdominal cavity, it really depends on the extent of the extent of the aneurysm being on the 7th intercostal space or the 9th intercostal space. So if you have normal aorta, what you have here, this is actually a schematic of a case that I did when I was a fellow at the Mayo Clinic with Dr. Bauer. What you have here, we have a clamp that we have done, a side biting clamp. You open the thoracic aorta. You are suturing this graft here. What you are doing here, you are not compromising flow to the liver, to the intestine, or to the lower extremity, or to the kidneys. Once you release this, then you can start sequentially taking individual branch, go to the celiac artery, perfuse, sew the celiac artery and perfuse the celiac artery, move on to the superior mesenteric artery, perfuse it, and move on to the renal, usually the left renal artery, perfuse it before going to the right renal artery. And when you're done, it looks exactly like this. So you perfuse the visceral arteries completely, then you move the clamp down, resect the aorta below where you had replaced, where you had done your proximal anastomosis, and then replace it completely. Patients do really, really well with this type of operation. So what are the outcomes? Also come from the Mayo Clinic. This is a series that included 43 patients that were treated with open repair with either thoracic or thoracoabdominal aortic aneurysm. Operative mortality in this case, not 2.3%, but 21%, obviously. And this is pretty good. Hospital length of stay, some of these patients stay in the hospital for 6 months. Late death was mostly related to cardiovascular disease or cancer. So if you survive the operation, you do well. This graph here depicts actually the normal population, 65 or older, in the state of Minnesota if you were to follow them over a 10-year period, the top of the graph. You see that this is the survival of normal patients with cardiovascular disease, however, no aortic aneurysm in the state of Minnesota. The second line here shows patients with aortic aneurysm treated at the Mayo Clinic if you follow them for a 10-year period. You see that at 10 years, about only 38% of the patients will be alive. However, for patients with infected aorta, or infected thoracoabdominal aorta, which is the graph is depicted here, about 33% of them will be alive. But note that if the patient with an infected aorta survived the first 2 years, their survival is actually pretty good. Here's this graph. So if you survive the first 2 years, your survival is no different than anyone else who had an aortic aneurysm treated without an infection and treated. The Taiwanese group also reported on 56 patients, and this included both thoracic aneurysm and infrarenal aortic aneurysm. Hospital length of stay was about also very long, and mortality was 23%, no different from the Mayo Clinic. Death after discharge was all reinfection related, 4 out of 4 patients. Late surgical complications were about 16%. For infrarenal aorta, look at this, 82% survival 1 year. If you have a thoracoabdominal aortic aneurysm, survival is way less than 50%, 47%. Bottom line is this. These are all the literature that I could find on all the surgical techniques that I have described to you today. Axillofemoral artery bypass, which I described, has a primary patency rate around 60 to 70%, and limb salvage, about 20% of these patients will have an amputation. Mortality is actually acceptable around 18 to 19%. The lowest mortality was reported by Dr. Claggett. He's 80 years old now, retired, and nobody else can duplicate his results. His mortality was 7%, but reinfection was 0%, and he also had some limb loss. Patients who have used a allograft, or these are cryopreserved graft, you can see the mortality is up to 22%, and limb salvage was quite good. And the rifampin-soaked experience come from the Mayo Clinic with excellent limb salvage. However, reinfection rate is quite high, as you can see. So clearly, outcomes of these open repair are underwhelming. Is there an endovascular option in patients with infected endografts? Well, some endovascular enthusiasts, as myself, will say perhaps there is one, but I didn't do this first. If you look at the literature in 1998, somebody reported on a whopping 3 patients, and that he placed an endograft. He said 30-day mortality was 0%, except it doesn't say what happens to those patients after 30 days. Patel et al. Placed endograft or thoracic stent graft, did TVAR in patients with 14 infected thoracic aneurysm. Early survival, this again 30 days, was about 86%. 3-year survival was 58%. Reinfection was really, really high. Can it all look at 48 patients, 30-day mortality of 11%, 20% of patients had persistent infection even with antibiotics, and 3-year survival was 30%. So you look at these results and say they're not that different than open repair, so why are we offering the patient open repair when they don't recover as fast as endovascular therapy? So I said, well, so why not use an endograft? Well, think about it. If you take your prosthesis, put it in an infected field, these patients are going to get infected again, ultimately. So the principle of surgery really apply. You have to remove dead tissue in order for you to expect good long-term results. That's why we don't use an endograft. Here's a 52-year-old male that we treated also when I was at the Mayo Clinic with an aortic dissection. He had multiple sternotomy. Came first, he had an ascending aortic aneurysm repair. Subsequently, he came back. I think his arch degenerated, so they did a conventional elephant trunk. He comes back now. He's from Alaska. He comes back with fever, malaise. They scanned him. He had an aortotracheal fistula. No open option. They asked Dr. Aldrich at the time if we could do anything. At the time, the Gore C-Tag, which is a thoracic stent graft that we use now a lot, had the trial for it had just completed, and the FDA hadn't approved it yet, so we couldn't use it. So we applied for compassionate use from the FDA because we thought this was the best graft to use in that case, and the FDA approved it, and the guys from Gore literally flew this graft from Arizona to the Mayo Clinic and reimplanted it in the patient. The patient did well. I graduated fellowship. It was January. Dr. Ordrich had asked me to write this case report. I started writing the case report, and he called me back and said, "Stop writing." He's like, "What happened?" He said, "You won't believe what happened to the patient." Says, his wife called, Dr. Ordrich said, he was having dinner on Christmas Day, had 2 kids, 3 and 5. Wasn't feeling well, having dinner with his wife and kids, forced himself to have dinner. He threw up blood on the table and dropped dead. And this exactly what happened when you put an infected graft inside something, when you put a graft inside an infection. These patients will die, antibiotics or not. Here's a case of a 60-year-old male that was referred to me 3 years ago now from Sioux Falls, South Dakota. He presented with abdominal pain radiating to the back. He was found to have a circular aneurysm, which I don't have the first pictures, but they went on and put an EVAR. He came back 2 weeks later with fevers, chills, and CT scan. As you can see here, Dr. Lessa can tell you that this is not normal. and the graft now has air in the aneurysm sac. So he was started on broad-spectrum antibiotics and sent to transfer here. And when he got here, we had no organism growing from this. I wanted to know exactly what was growing, so I'll ask Dr. Engstrom if he could go in and tap that the abscess. And they tapped the abscess. We sent it for culture. It wasn't growing anything. So I decided to do a PET scan. And on the PET scan, you can see that if this video can play, that you can see that there's increased uptake, shortly here you'll start seeing it, around the spine here and the aorta. Not only that, but look at this abscess, and the ureter on the left side is really lighting up. If you look at this here, you can see that the L2, L3, and L4 in the body are completely involved in this. So I solicited the help of Dr. Pinto with spine surgery. I do a lot of spine exposures. I can expose L2 to S1 in about 30 minutes, maybe less. In this case, it took me 3 hours to expose. After exposing it, you can see here Dr. Pinto has resected L2 all the way to L5, and he put an expandable cage there. After he is done, I enter the aortic sac, I remove the undergraft, and I use a cryopreserved graft. I reconstructed it, and I repair with the, I wrapped it with omentum. So obviously the patient needs to be fixed again in the back, so we kept him intubated and let him flat because he had a long day. Kept him in the ICU. Dr. Pinto went back the next day, and they put screws in the back and a rod in order to fix him. So now he's stable. He did really well. However, he came back, presented back to the Heart Hospital in Sioux Falls with claudication by lateral lower extremities. This is a year ago, off antibiotics. So they did a CT scan, and his aorta actually had narrowed significantly. In this case, I brought him in and I put an undergraft that I soaked in rifampin, and he's done really, really well. He went back. He's a paramedic and doing extremely well. He's about 3 years out now. So what are really endovascular outcomes? Most of us will agree that endovascular solutions are temporizing. So if the patient comes in bleeding, hemorrhaging, put a stent graft, get the patient stable, and then go to the operating room and then try to replace it. But some people will argue that, no, this is not the case. The good thing about living to Europe is, number one, you live in Europe, and number two, you have socialized medicine. And the good thing about socialized medicine is that you have to report your outcomes to the government. So here's a Sweden experience. They looked at infected aneurysm in the entire country of Sweden, about 132 patients. And look at this. If you look starting in 1994 to 2000, there were 0 patients that were treated with endovascular therapy. Fast forward from 2001 to 2007, 58% of the patients with primary mycotic aneurysm in Sweden were undergoing repair with a stent graft. And if you go in 2014, up to 60% of the patients are now being treated with undergraft. You ask what's going on. So why the increased interest in patients with undergraft? So here's an example of a case report that I reviewed for aneurysmal vascular surgery. I thought it was fascinating, and I decided to include it here. 44-year-old male, IV drug abuser that presented with Staphylococcus aureus endocarditis and bacteremia. He had previous aortic bilateral femoral artery bypass that had occluded, and then they went in and put a stent graft. They put a stent graft in both iliac arteries. Came back with this infection. Cardiac surgery took the patient, scanned them. You can see the pseudoaneurysm here. Cardiac surgery took him to the operating room, replaced his valve, and did well from that. They scanned him 10 days later. You can see the pseudoaneurysm is this big. Obviously, you have to fix it. The question is how to repair it. They went in. They tried to go do open. They could not get into the abdomen. So they changed their mind. They took 3 grams of 60 milliliter per deciliter of rifampin into 30 cc's of saline, and then flushed a graft, a cooked graft rather, that looked like this. And then they went and repaired the patient. Immediately post-operatively, you can see air in the aneurysm sac expected. The patient has an infection. Three months later, air is gone, so the patient's getting better. A year later, the aneurysm sac is completely remodeled and the patient's done very well. So perhaps this is their publication that they published, I believe, in 2014 for Annals of Vascular Surgery. So perhaps there's something to be said about this. So what are really mortality of patients with an infected endograft undergoing endovascular repair? Well, if they survive the first year or two, they actually do really well. They do as well as the patients that are repaired using open repair. So how do we get the patient to this 2-year hump? How do we maximize or optimize endovascular therapy? Well, Dr. Belair came up with an idea. He says, what if I put a drain into the abscess? In 1998, he looked at 28 patients, put a drain into abscess, or hospital mortality was 21%. 7 patients died within 1 year, so about 45% mortality at 1 year. However, only 41 patients were, in this 41% of patients were on antibiotics. The rest of them only had drains in place. So mortality-based, drain or not, is about 50%. So drains don't work. No, so fast, says this gentleman from the United Kingdom. He says, what if I put a drain, instead of just leaving it alone, I lavage the aneurysm sac. I lavage it with antibiotics. So he treated 10 patients with grafts. He lavaged the solution, he used a solution of gentamicin, Pen-G, and metronidazole, and irrigated the graft. How long, it's unknown. And he reported only 2 reinfection or survival of 80% at 1 year. Dr. Morris described a case of a patient with VRE where he put in the graft into the aneurysm sac after putting a stent graft, used linezolid for 28 days, and at 7 months there was resolution of the infection. So in conclusion, mycotic aneurysms are rare but deadly. Medical management alone results in nearly 100% mortality. Open surgical repair is better than conservative management but carries a risk of mortality up to 20% and morbidity of up to 50%. Endovascular treatment is gaining popularity, especially for primary. I say primary, if you have a fistula, it doesn't make sense to put a stent graft there. Primary infected aortic patients without enteric contaminations. It may be used as a bridge to open surgery in patients with massive hemorrhage. So if patient comes in bleeding, this can be used as a bridge. So before I close though, I wanted to entice you, and especially as I prepare to go back to the Congo, as you guys know about the mission work I do in the Congo, I'm hoping, this is a collage that was sent to me the night before last night, actually, by one of the doctors that I work with there. I'm hoping to entice some of you guys to come and do some work. It's great. We do this through the Dikembe Mutombo Foundation. Very, very good cause. We work really hard, but as you can see, it's not really only work. We have a lot of fun. So thank you very much. If you're interested, we really would love to have you come with us. And I'll take any questions with that. Yes, sir.
Good talk. I mean, I use the term mycotic aneurysm all the time. Should we be going away from mycotic aneurysm? Because one, it's not, it's a misnomer, and two, and it's not as, there's always that difference between like a primary infected aneurysm, secondary infected aneurysm, infected graft.
That's a really good point, Dr. Stevenson. I think we talked about it a little bit. So the way this came about, it came from Dr. Osler in 1885. So when he stained this with Gram stain, this is the first time Gram stain was used. He looked under the microscope. They look like a fungus rather than a bacteria. That's where it came about. Should it be used? Perhaps not. I don't think it can be used. And you're right. We discussed the term mycotic is really different. Primary mycotic aneurysm versus graft-related infection. Perhaps we need to change it. Are we going to change it? But as you know, we love tradition. We're probably stuck in that tradition. Yes, sir.
Fantastic talk. Thanks.
Thank you.
When you're in the thorax and you're trying to decide where to resect, how do you know how far to go and what's the risk of paraplegia?
Yeah, that's a really, really good point. I had a slide here discussing the risk of paraplegia, but then I put it away. So, how far do you go? So when we do the risk of paraplegia, that's a huge kind of warrant. How far you go, Dr. Lesser, when in the operating room, you know what dead tissue is and what good tissue is. Dead tissue would just be that. If you put a clamp in there, it just falls apart. And when you're resecting it, you can literally see that this is not good tissue. You can point, it's like cutting an apple. You can see, oh, this apple's dead here. It's dead. Oh, this is a good piece of it. You will know. Sometimes you don't know on the CT scan, but sometimes when you get in the operating room, you will know. When we were doing open thoracoabdominal aortic aneurysm, we will take intercostals. A lot of the time in medical school, we talked about this artery of Adamquist as if the artery that supplies the spine. It's not always just one of them. It can be found anywhere between T8 all the way. I've seen it around L1 or L2. It can be right there. It can be just one artery, or it can be multiple arteries. So we used to take a graft, Dr. Lesser, when we resected the aorta. We take a graft that we literally put a patch on the bottom of the aorta around the aggregate where you see those intercostal vessels. So it was called an intercostal patch, and you move it back into the aorta. The problem is, long term, this patch tends to become aneurysmal. Then you have to go in and put a stent graft in it. The risk of paraplegia is something that we're really getting to. Paraplegia is something that that's under intense investigation. We believe that it's not only due to resection of the intercostal vessels or lumbar artery, but also due to inflammatory processes. In fact, we think more so that it's due to inflammatory process than it's due to ligation of the intercostal vessels. Here's the reason why. There was a really good study from Mount Sinai that took 40 pigs. They broke them down into two groups. The first group, they cut all the lumbar artery and all the intercostal artery on the same day and put the stent graft. They stented the entire aorta the same day. They took the second group, they cut all the intercostal vessels, all the lumbar arteries, left them alone for a month or 3 weeks, I think, and came back and put stent graft, stented the entire aorta in the second group. In the first group that had both procedures at the same time, 50% of the pig developed paraplegia. None of the pig in the second group developed paraplegia. So we think that staging the procedure, that's why in endovascular, when I do thoracoabdominal aortic aneurysm, I stage them. I put a thoracic stent graft first, and then I do the fenestrated piece later to mitigate the risk of paraplegia. We have even moved away from routinely, prophylactically putting spinal drain, even for thoracoabdominal aortic aneurysm for that reason, because you can also get hemorrhage or a bleed. That's one of the complications of the spinal drain, and you develop paraplegia because of subdural hematoma from the cord structures. So it's a very difficult problem that we don't have good answer, but that we're getting clarity. I think inflammation has more to do with it than ligating these vessels in of itself, because they are collaterals if you think about it. So the anterior spinal ligament is supplied by branches of the internal iliac artery and the left vertebral artery that comes down and then joined. So as long as the left vertebral artery is open and the internal iliac arteries are open, and if you keep the mean arterial pressure up, technically the spine should still be getting perfused even if you cut all the lumbar arteries. Yes, sir.
Jesse, thanks. That was a great talk. As far as infected blood vessels in general, is there a size where, like, do you see these infections in smaller arterial segments, or is it just localized to the large vessels such as the aorta?
The ones that we really see most is in the aorta. And usually there's a plaque, either atherosclerotic plaque, or they have an aneurysm, or they have a penetrating aortic ulcer. The patient gets some type of infection, systemic infection, blood circulate, and then there's an injury into the intima and the media of the aorta, then the aorta gets seeded with some type of infection, and then it develops into a pseudoaneurysm that over time may rupture. I don't know, Dr. Stevenson, have you seen it in small vessels?
Usually it's, with septic emboli.
Yes.
So like mycotic aneurysms, they usually hit branch points, common femoral artery, popliteal aneurysm, like the trifurcation,
Sure.
brachial. We see that, I guess, I think, but yeah, sort of primary infection of, smaller arteries usually doesn't, I think that's not common. Usually embolic. We assume it's embolic. Sometimes you don't see the emboli.
Yes. Yes.
Yes, we do have one online question. It comes from Dr. Peterson, who says, thanks so much for the review. The question is, what do you think is the ideal endograft for EVAR when temporizing these situations?
Okay, so that's a good question. So not all grafts are the same. Okay, not all grafts are made the same. Some grafts are more resistant to infection than others. Gore graft, for instance, probably will be less resistant to the infection as opposed to cook graft because of the type of material that's made, or Medtronic graft because of the type of material that Medtronic and Gore graft uses. The advantage of using a Gore graft is that we know that rifampin, if you were to soak it in a rifampin, we know that rifampin takes really well in dicron, and people think that it will infer that it will take well in a Gore graft as opposed to a Cook or Medtronic graft. But if you are just putting it there, just temporizing it, I say put in a graft with no suprarenal fixation graft, right? Because it's easier to take out. So Cook and Medtronic graft have suprarenal struts. So when you go up above the renal artery, they literally have these laser cut things, barbs, that once you deploy it, they get embedded in the wall of the aorta. And when it comes time to take it out, we have a technique to take it out. However, it's not as easy to take out as a Gore graft. So if I were doing it as a temporizing measure, I'll put a Gore graft because I can easily take it out as opposed to graft with suprarenal fixation barbs. Thank you so much.